Hospice of Santa Cruz County in California before coming all the way here to Maine. She has dedicated her career to palliative care in Maine. Committed to providing compassionate medical care to those with serious illness, and believes that that can only happen with truthful conversations throughout the spectrum of care. And Maureen Giffin, RN, BSN, CNE. She's our MDI. I'm not defining what all of those mean, but I wanted to get them all in. Okay. She's the palliative care nurse at MDI Hospital in Bar Harbor. She's worked in oncology, hospice, and palliative care for over 35 years, focusing her clinical expertise on symptom management, quality of life issues, and education about end-of-life care. She's been a hospice outreach nurse and a hospice manager at Hancock County Home Care. She's also instrumental in co-developing POLST education, that's Physician's Orders for Life-Sustaining Treatment, Education and Training for Maine's program. She's our palliative care nurse at MDI Hospital. And then Donna Wiegle, okay, she's a cancer survivor on the panel, diagnosed with stage 3B ovarian cancer in April 2016, has been in remission for 13 months. And hospitalized many times over the past few years for small bowel obstructions. The most recent this past June, so this has been something that she's had to deal with on an ongoing basis. And living on Swan Island, it ain't been easy. Okay? During that hospital stay, she was introduced to MDI's palliative care team and is here today to share her experience from a patient's point of view.
Thank you, Lynn. Nice job. I'm really thrilled to be here facilitating this panel. For one thing, I get to facilitate with all these amazing women who bring so much to this discussion, and they get to answer the questions. So, as mentioned, I am Jody, Wolford Tucker, and I serve as Executive Director of Hospice Volunteers of Hancock County. And we work collaboratively with all of the organizations that these folks have been a part of for years, and are grateful for the opportunity, feel it is a privilege to serve as members of the team with these folks, which you're going to hear more about, because that's kind of the crux of palliative care, is the team approach. And so we'll hear more about that from these guys. So the purpose of today's panel is to help introduce what is palliative care, how does it differ from hospice, which is often a confusion that people hold in the community. This is so great, I'm seeing all these heads nodding. Thank you so much for that affirmation. What are the benefits to be had by being offered and accepting palliative care for both patients and families? So I would just like to take a moment to give folks here an opportunity. Is there anything more about your relationship with palliative care or your work that you would like to share that Lynn didn't mention?
I think she covered it.
Okay,
Yeah.
All right, because that was supposed to be our next step, but Lynn jumped in and introduced everybody.
Oh.
No, that's fine. We just didn't know you were going to. So what I wanted to make sure in that introduction phase is that you all were given a picture of what the relationship is with palliative care that each of these panel members are representing or bringing to the table. So if that's adequately covered, then we'll leave that one. And if it's all right with you, Donna, can we start with your story?
Oh, sure.
So I was on the patient panel last year, so some of you that were here last year may remember me. So I'll go brief about that, but I was diagnosed with stage 3B ovarian cancer in April of 2016. At the time, I had a complete bowel obstruction, which required surgery, which I had at MDI Hospital with Dr. Charlie Hendricks. And during that surgery to correct the bowel obstruction, he found some nodules on the outside of my small intestine, which then came back as stage 3 ovarian cancer. I did a shortened course of chemo last year. Stopped partway through my frontline chemo due to the side effects that I had severe neuropathy in my feet. My type of ovarian cancer is called low-grade serous, and it is considered to be chemo-resistant. Only 5% of patients that undergo chemotherapy with that type of cancer have a positive response to the chemotherapy. I was unable to have surgery, went to Dana-Farber for a second opinion due to other complications that I had, so I had a very poor prognosis coming out of there. But I am in remission for 13 months, which Lynn said, which was unexpected. And my experience with the palliative care team, how I got involved with the palliative care team, I have ongoing problems with small bowel obstructions, and I had one in June of this year. Ended up in MDI hospital as an inpatient, and I don't even know, I'm going to say the nurse came to me and said, "Would you welcome a visit from the palliative care team?" And I said to myself, oh shit. I didn't really know what the palliative care team was, but I thought they were sort of kind of like hospice or, in that realm. And I thought, well, they must have seen something on my scan today that I don't know about, and I'm pretty up on what's going on with my health condition. So I said yes. I thought I'd take a chance on these guys. So Dr. Little came in to see me with Lynn Asap, who's a social worker on that palliative care group. And it was a great visit. They listened. Dr. Little is a tremendously good listener. And they let me tell my story of how I had gotten to that point. And then I thought, what are they going to do for me? And what the message that I got from them after talking with them at length was they were there to support me in any way that they could, but mostly to support me in having a good quality of life moving forward, either maintaining the quality of life that I had at the current time or regaining more quality of life as I moved forward through my health issues that I had. And so I've been able to work with both Dr. Little, Maureen, Lynn, as well as Heather Sinclair, who's another social worker at the hospital, in various ways that the palliative care can offer some services to me. I won't get into them right now, or should I? Should I explain what those services are? For example, and I'll be brief about this. Dr. Little accompanied me to a visit with Dr. Hendricks, my surgeon over at MDI Hospital, so that we could explore any and all options to resolve the bowel obstruction, of which no options are desirable or acceptable to me. We talked about pain management and what we could do around pain management at the time of the bowel obstructions. And so it was great to have her there as a second set of ears listening in, because she knows a lot about my case as well as Dr. Hendricks does. Maureen has been out to Swans Island twice, and that's really a big deal, coming to Swans Island to see a patient. It's not like going to Ellsworth to see a patient or Bar Harbor. So she's come out on the ferry boat twice to see me on the island. We've talked about many, many different things, pain management being one of them, possibility of exploring the options of Social Security disability and Medicare and things like that. And so that's been really great. And I've been in contact with social workers as well, and they've been helping me out as well. So I think they have a whole realm of things that they can offer to a patient. And otherwise, you're navigating all this by yourself, and you have these experts that are here to help us. I'll end on that.
Wait, Donna, tell them what you do out on Swans Island.
Yeah.
Oh, what do I do Lynn says tell you what I do on Swans Island. So we have a small health clinic out there. We have a community of 350 year-round residents and about 1,000 in the summer. And I run the health center out there. So I've been running the health center for about 10 years out there. And last year when I was diagnosed with my cancer, I did hire a part-time person to work with me because I've been running the center single-handedly. And my helper doesn't get many hours now because I'm better. But, and we have a great relationship with MDI Hospitals, really our supporting organization that helps us with our health center. Wonderful.
Thank you, Donna. That was great. That gave a pretty good picture of what palliative care might do for a patient at the stage Donna was at, didn't it?
Yes.
Yeah. Okay, well, you will have opportunities for questions. Are we okay to let them ask questions anytime, or do you want to go through your spiel first? Okay. All right. Well, I was going to say the next question that we talked about was definition of what palliative care is, and then if you want to include how is it different from hospice, that's fine too, or that can be a next step.
Is this on?
No.
It doesn't appear to be. I don't think it's working. Yeah, I'll just use this. Thank you. Hi, I'm Maureen Giffin. I'm the palliative care nurse at MDI.
And it's interesting to define palliative care. So if you have a heart condition, you would go see a cardiologist. Or if you had some lung problems, you might see a pulmonologist. And so I could go on and on and on. If you had some kidney problems, you'd see your urologist. So also, palliative care is not defined by age group. So if you're as a child, you see a pediatric physician, or older adults see geriatricians. So it's not defined by age group services. It's an approach to care. So palliative care is an approach to care. It serves people of all ages and all diagnoses if they have a critical or a serious diagnosis. It's a team approach to symptom management is what palliative care is. It focuses on quality of life and comfort. The goal is much more than dying. Palliative care is about living through meticulous attention to control of pain and other symptoms. The palliative care team supports the patient emotionally, spiritually. It supports the patient's cultural needs, and it supports the patient in maximizing their function. So a lot of times when patients are in the hospital, there's a lot of technology that's used for diagnosis and treatment. In palliative care, we look at the symptoms, the baseline symptoms of pain, symptoms like insomnia, anxiety, agitation, constipation, problems, all kinds of problems that patients have. And so we try to look at how these symptoms might be affecting their life and what we can do to help increase their quality of life. And so we work as a team. As I said, we have social workers on our team. The nurse on our team is myself, Dr. Little, who provides us direction, who's an expert in symptom management. And so we work as a team to encompass the patient and help provide symptom relief. So I wanted to talk about the difference between palliative care and hospice. So hospice is a Medicare benefit in which people elect if they have a prognosis of 6 months or less. And so hospice is philosophy driven. So if a patient is of the philosophy that I just want to be kept comfortable until the end of my life, I don't want any more treatment, they may elect their hospice benefit. And that would be the last 6 months of their life. It doesn't mean the hospice benefit can't be extended. It certainly can be extended if they still have a poor prognosis. With palliative care, we like to get in very soon after somebody is diagnosed with a serious illness, so we can help promote their quality of life and meticulous detail to symptom management to increase their quality of life. When people receive palliative care, most likely they're receiving concurrent active treatments for their cancer or for a non-cancer diagnosis. So that's sort of in a nutshell what palliative care is. There's a lot of disease processes in which that we're involved with other than cancer diagnoses, such as heart disease, pulmonary disease, COPD, ALS, MS, those kinds of diseases. So I'd be happy to take questions about your questions that you might have between the difference of hospice and palliative care. Go ahead.
How about Alzheimer's? Do you work with Alzheimer's patients?
We do. We do work with people with Alzheimer's and dementia because they certainly have needs about quality of life, and we're happily able to see those patients. Because when you think of somebody with Alzheimer's disease, all of those symptoms that I just mentioned, whatever they are, whether it's insomnia or pain or agitation, those kinds of things, the difference between dementia and delirium, what might be happening to them, those are a lot of issues that we can address.
Are you the only group PAL care in Hancock County? Are there any other groups like you?
So I'm going to let Dr. Little describe to you our program and answer your question.
Hi, everybody.
I'm Vanessa. I'm a palliative care doctor, and before I answer your question, I'm going to say a little bit more about palliative care and hospice. Thank you, Maureen, for that thorough explanation. Because what I wanted to say is that hospice is a way of providing palliative care, but it's for a certain subset of population, like Maureen said. Someone with an expected life expectancy of about 6 months, even though it's very hard to know with certainty, and somebody who doesn't want any more curative treatment for their main hospice diagnosis, what they're being referred to hospice for. But palliative care is that same philosophy of care moved and applied to a broader population. So somebody with a serious illness that's impacting their quality of life. And when you brought up a patient with Alzheimer's, certainly I have taken care of people with Alzheimer's or other types of dementia, and someone with dementia could be on hospice when it is very near the end of life. But much earlier on, not only are there symptom management needs, but also family support. And both in palliative care, whether you're talking about an inpatient consult program or an outpatient program, the unit of care is not only the patient, it's the whole family. And we love when we see people in the hospital because that you usually get a lot of visitors in there. Or in the clinic, how many people can we stuff into this little family exam room to have a family meeting? Because as we heard the stories this morning, so much about the experience of cancer or other serious illnesses is the rest of the person's life is impacted, and the family all has responses. The communication within the family itself is something palliative care can help support, but also the communication around providers. There's a lot of challenges in our healthcare system right now, and there always will be, but one of the things palliative care can be is kind of the glue amongst many specialists and primary care physicians and alternative providers, just trying to make sure that we're all acting on the most valid and true and up-to-date information, and that the patient knows all that too, or as much as they want to know. When I was listening to the talks this morning, I wanted to make sure that I really said that palliative care is not giving up hope. If anything, to me, palliative care is tuning into to being hopeful and clarifying along a disease process, what specifically are we hoping for, what are we working for, and by we, the patient is driving the bus. And our team is just like, okay, what is it gonna be? That's what we're gonna help you do. If it's symptom management, we're on that. If you're worried about finances, then we're on that. We've got a social worker, and what can we creatively do to solve this problem? I mean, one of my biggest sadnesses as just a human being in this country is that I think that having a serious illness is scary enough. I am very sad when people have to complicate their experience by lack of access or a sense of lack of access to healthcare. There's lots of diagnoses that are appropriate for palliative care. We talked about dementia and lung disease, heart failure. There's palliative care programs across the country that is just anybody that is referred for surgeries that are potentially especially dangerous will have a palliative care consult just by default to talk about goals of care, advanced care planning. What if the surgery doesn't go out? We're all hoping, kind of those what if conversations. So how to receive palliative care? I will now get to your question. And the MDI program right now is a pilot project. So we have generous funding from the local donors. We started with just inpatient consults. So for the last, if I was here a few months ago, I would have said, you have to be admitted to the hospital, and then the hospitalists will invite us in for a consult. But now we have a presence in the clinic. So your primary provider will put in a request, and I see patients in 3 of the MDI hospital affiliated clinics, Trenton, Southwest Harbor, and Cooper Gilmore. The idea of that is to see people in the clinic that is their home as much as possible, where people are comfortable going and you already know the MA and the front staff and everything. And then the third phase, where we're really hoping to get, is to be able to see people at home. But we have a lot of work to get there. So that's the MDI hospital program. There also is palliative care available in this county through VNA. Here they can. They're doing people have to also meet criteria for home care, so it's a little bit different model. And, and Eastern Maine Medical Center has had a palliative care program for many years, run by Jim Hancock. They have inpatient consults, outpatient visits, and I know they do occasional home visits. So those are the places I know of. There's also palliative care through Hospice Volunteers of Hancock County, which is a non-medical, but but doesn't meet, you don't have to meet criteria around any hospice eligibility or home care. They're a wonderful and underutilized resource. Any other things I forgot? Yeah.
Is palliative care covered under insurance?
Yes and no. So, like Maureen talked about other specialist consultants, my visit is billable just like that under Medicare or commercial insurance. The part that is not is that it, usually palliative care takes much more time, and the rest of the team members aren't. So most, I would dare to say all palliative care programs exist because of philanthropic support or by being able to prove to payers that we are valuable resources in terms of quality, in terms of cost savings, in terms of patient satisfaction, some other management. Because it isn't like we can fund ourselves.
Because we see quite a few people at the Beth Wright Center who I think could benefit from palliative care. We've been talking, who are dealing with symptoms, and they come to the Beth Wright Center to do yoga and other things to deal with their symptoms. And so I mentioned palliative care programs. So what's the easiest way to get them into that system?
So if they have an MDI hospital primary physician, they should ask their physician about making a referral. And then if they have a different provider, then I think, see if they're homebound and therefore meet criteria for home care or Eastern Maine.
And having their primary care provider.
Make their referral, yeah. I don't know if you could just call up Eastern Maine and make your own appointment.
Is Becky here? She'll be able to tell us. You're talking Becky Wiegle?
Oh,
She's a social worker at Eastern Maine. And there is a sort of a process you go through. I don't know that everybody gets a palliative referral. And I'll try to find out what that is and let people know.
It's part of this whole thing. So if you go to a doctor somewhere else and they don't have a palliative care program, can you go to another one?
Yes. Unfortunately, I can't say you can come to the MDI hospital one right now, just because it's in this pilot phase. Hopefully in a year from now I'll be able to say something different, but you could, there are other programs. I mean, I know there's, Dana-Farber has a program, and somebody's talking about Sloan Kettering has a program. I mean, I've seen people have palliative care consults in some of these academic places when they're there for treatment, New Med, and so I don't know if I answered your question. But the other thing I want to say is, well, it isn't that palliative care can only be provided by specialists in training of palliative care. A lot of palliative care and focus on quality of life can be done with your primary care doctor if they are open to it. No, okay.
I will say, we got into this at the last conference. There's something happening out there, and you guys are like little angels up there for me today. This is like what medical stuff used to be. It's kind of like we're going forward but backwards at the same time. Does that make sense?
A lot of what our team is doing, not only at MDI at least, is education. Because it isn't that everybody that has an interest in quality of life necessarily needs to come to us. So, I mean, I'd love to talk to you more about what, in private, about what resources might be available, but between social work and Beth Wright Center, hospice volunteers, I don't know.
I think it's also true that when you talk about us sort of being an educational place right now, there are a lot of providers who also confuse palliative and hospice. Mm-hmm. And so they'll say to us, oh, they're not there yet, meaning not ready for hospice. Right. And so we're in the, we're in that phase where it's not widely recognized yet. what palliative care can be.
You're exactly right, and pulling in those other, several other comments, thank you for mentioning that Hospice Volunteers in Hancock County is in a unique position where we are an independent program, so we're not answering to Medicare's checklists, and we're not only affiliated with one of the local hospitals. We are truly privileged to be able to work with all of the providers in the area. And I have actually sat on the newly developing palliative care program at Maine Coast, which is now, of course, part of the bigger Eastern Maine organization. And there's a huge push, as Dr. Little mentioned, coordinated by Dr. Van Kirk, who's based in Bangor, but there's a huge push system-wide for Eastern Maine to try to advance the availability and understanding of palliative care. So great strides are being made, and there's still a long way to go. And just to jump on that, one more opportunity, just to say that our program we don't charge for our services. So if there's a way, we being Hospice Volunteers in Hancock County, if there's a way that we can help be a bridge, get the folks connected with the different ones that we're aware of in the community, we're certainly happy to do that. And I would just, real quick conceptualization, hospice is like a subset of palliative care. Palliative care is the bigger umbrella, and hospice is one type of approach to the holistic team delivery of services. So with that, I think it's a perfect jumping off place for what we had as our next question is, what are some of the challenges facing palliative care and the delivery of palliative care services right now?
So I think some of the challenges are a lot of what we've just mentioned as far as just education about what palliative care is, not only in the community, but in the healthcare community also. So I think that's why programs like this is really, really helpful, just to educate folks about what palliative care is. It's a service and an approach to care that goes out the trajectory of the disease. And so we'd like to be able to follow people. It's not just a one-time service. We'd like to follow people in their disease process and in their conversation about their goals of care. And it might be that somebody is receiving treatment and they have progressed, and hopefully all along we're managing their symptoms, and so that we're doing everything we can to maximize their quality of life. But it may be that they're sort of closer to the end process and their philosophy has changed, that they would like to be kept comfortable at home, and we would transition them to a hospice, a medical hospice, and hopefully the Hospice Volunteers. So that's our connection. But so that's basically what we do.
So I have a question. Obviously this is a very patient-centric approach.
Mm-hmm.
You're in the pilot right now. What is going to get you past the pilot to an actual program? What pushes you beyond that to become an actual viable program?
Oh, I wish I knew. We need a crystal ball. I mean, that's what we're trying to anticipate and predict and get the right information so that it's present and available to show whoever is interested at the time. I mean, it'll be things that we're working on are, quality, making sure we are doing what we say we're doing, measuring that, asking patients and families if they like what they're seeing, asking the providers if they like working with us.
So who provides the actual approval, I guess, is the question. It's who says, okay, you are not a pilot program anymore, you were a...
Funding, it'll be funding.
It's all around funding.
Mm-hmm. And that's what I mean by anticipating what potential funders might be. And we're in a place in healthcare where things are changing, and what the scene right now may not be what exists in 2 years from now, and how people are reimbursed. So we're certainly healthcare is moving towards a quality-based model, and palliative care certainly has a place in that role. And nationally, I think that's pretty well recognized. But this fee-for-service we bill more, we make more, the more procedures we do, the more tests we run, the more treatment you have. That doesn't quite match with.
I think I work at the Mary Dow Center in Ellsworth, and I think one of the big things that needs to get out there is education piece, because what I see from our scope of practice is that we are using Eastern Maine palliative care for pain management in this climate of being very scared and being questioned. Doctors are very skittish about pain medication, so we're using it that rather than, I mean, Ellsworth needs Dr. Little more than anything. I'm sitting here, I'm thinking many of my patients have an MDI address that I can use, because that's very lacking up the road, and that whole approach is really, as a nurse, what we're looking for. And I don't know, we're not getting very much feedback from Eastern Maine from the palliative care. It seems to be a one-shot deal, and patients, the little bit that I've gotten back, haven't received the loving wraparound team approach of Dr. Little's clinic. So whatever we can do to make you permanent and funded and part of Ellsworth.
I think the frustration is that there are two programs sort of parallel getting going. The MDI farther ahead, that there couldn't be more interaction with those programs in the planning stage. It's almost like palliative care for the palliative care program. It's something that.
Well, and one of the challenges is exactly that around education, and I did see your hand, I'll come right back in a minute. In the discussions that I've been part of in terms of developing the palliative care program locally, we've even gone to calling it a comfort care program, because there's so many myths and misconceptions about what palliative care is, and people thinking, oh shit, when they hear the term, because they think it means they're dying, and to be able to create a more positive image of what it is, and that includes the providers. Educating who do we refer to when this patient could benefit from palliative care, and by the way, and what is that? So there's it's still in the infant stage, and that's surprising because it's been around a while, but it hasn't really found its footing as much as we hope that it will. Anything you'd like to add to that? And then this lady has a question.
Actually, there are a lot of myths around palliative care, and so some of the myths are palliative care is called in when nothing further can be done. Or another myth is if I accept palliative care, nothing further will be done. And another myth is palliative care equals giving up hope. And another myth is palliative care should be considered at the very end of life. Or palliative care is a place rather than an approach. And palliative care is for cancer only. Or palliative care is just for old people. So those are all myths about palliative care, and none of them are true. So thank you for bringing up the myths, Jody. And you had a question?
Well, it's more of an observation. I've just spent 6 years as a chaplain for the Barbara Bush Children's Hospital, where I worked with pediatric and perinatal palliative, which is in its embryonic stage here in Maine. One of the things that was very clear to me was that there are a lot of very skilled, very caring physicians, no matter what their specialty is, who can do good palliative care. But the psychosocial aspect of it is what's often lacking, and a lot of that has to do with funding. As a chaplain, my time was not billable, but as a board-certified chaplain, what I was doing had very little to do with religion and a lot to do with questions of meaning, which is hugely important, whether you're the parent of an infant who's not going to be able to have much of a life after birth, or whether you're a child, whatever. It's very complex, and I think that the education, there's a very nuts and bolts piece about this is going to save the hospital money upstream. It's
It's not gonna save it now. It's gonna save it when you don't have repeated admissions for fetal care. Especially with children, people really want their child at home. They really need that support in the home. And that gets at provider support, because this issue of, I don't want to take away hope. Well, if the only hope is going to be hope for cure, and there's no cure, then you're giving the person false hope, and that's not good medicine. It's not good care. So I would love to see the role of social work, and particularly of spiritual care, lifted up more in all of what we're talking about, because there's also the research that says that relationships and the opportunity to feel accompanied is a key part of it.
So I wanted to add something from the patient point of view. I don't know how many of you in here are patients, but when you finish up your treatment, whether it be radiation, chemotherapy, whatever it is, in my particular case, I was going to oncology every single week for chemotherapy. And so I saw my team every single week. I saw my oncologist every third week. When I finished my treatment, that was it. I was set free. And that is such a frightening feeling for a cancer patient who has been so ingrained with their team for months, having treatment, having feedback, having blood work done every week, knowing what your counts are, tracking that, and then you're told, we'll see you in 3 months. Well, my God, and it's like them saying, go home and resume your life, your normal life. Your normal life is completely gone now. You have to find a new normal. And I think what the palliative care team can do is they can be those people that you can pick up the phone and call, or come in and see them in the clinic, or come to your house and just check up on you. How are you doing? How are things going? You know, do you need us to assist you in any particular way? Because your oncologist who you're seeing every 3 months, he comes through the door, he says, you look fantastic, how you doing? You say, oh, I'm feeling good. And the visit might be 15 minutes maximum, maybe, if there's nothing bad that he needs to share with you about your counts and things like that. And then you're going on your own for another 3 months. And I'm a pretty independent person, and I have a great caregiver in my husband, but that's a really frightening thing. And I said that to my oncology people. I was there this morning to have my port flush, and I said, you know, when you set the patients free, you need to call them once a month. How you doing? They need to hear from you, because it's kind of a scary thing, you know, because your normal is completely gone, and the new normal might really suck. In my case, I think my new normal is fine. I've accepted it. I have great mental health. I'm a good advocate for what I need. And in my case, I say this to people too. I don't really care how long I live. I care how well I live. And I think palliative care is able to help patients recognize that and figure out what that means to each individual. Because the length of time for me isn't the important thing. It's the quality of life that I'm going to have from here to the end.
Thank you, Donna.
Respond to her thing? That I'm sorry, can I don't want to take
Sure.
that I agree with you, I'm sitting here, my head's going up and down. I got graduated from the surgeon at 10 years. And I'm like, are you kidding me? I felt like my support, my safety net was completely gone. So I'm so excited to hear about this. Thank you.
So that's an important thing for us to file in our, you know, kind of what we're going to look at next here. You know, what's on the horizon for palliative care. And I'd like to include what you have said about the clergy members. I'm wondering, I'm going to put this out there, and kind of it ties back in with, you know, like cloning you. As Maureen mentioned, there's a hospice medical benefit that Medicare and other insurances include. So part of that hospice definition includes the medical director, the nurses, the home health aides, the physical therapists, the social workers, the clergy people, and volunteers. That's all mandated as part of the team. Is the future of palliative care for there to be a specific palliative benefit that will define the team members so that people will start making the connections with all of these providers? What do you think?
I mean, I don't know. What I think, in terms of like if any definition would get changed, I wonder if the hospice criteria might be reevaluated. I think there's places in the country that are experimenting with this. There's certain insurance companies that have experimented in taking away the waiving access to curative treatment. Like, what if you didn't have to do that? You could have hospice and curative treatment, and would it still make cost? I don't know. Would it still make sense cost-wise? I think there's lots of ways palliative care can be funded in creative ways, and people are looking at it all over the country. ACOs, accountable care organizations, have a vested interest in people not readmitting themselves, getting to the hospital for unneeded care. So when we look about paying for quality, fortunately in palliative care, and that's one of the reasons I love it, quality care also often means less cost, and there aren't many places in the world that we find that. So when I see the future in palliative care and the success of it in our nation, I think it will be one of those, maybe a combination of those.
Yeah, I just feel optimistic about palliative care. I can't imagine this program going away. I think it's hugely valuable. I mean, we're talking about quality of life. I think the patients out there will, like you're asking, like, I'm just set free after 3 months and I have issues, and those issues aren't always brought up at a doctor's office. You just have a certain amount of time. So I feel like, I don't feel like it's going to go away. And I feel like a palliative approach should be the thread in the tapestry of all healthcare, for sure.
I was just wondering, I live in Lubec, Maine, and we're in Washington County where we are limited with services and things. And I think we have to kind of think outside the box a little, because I'm wondering about some palliative care training for, like, I work for a federally qualified health center, so we have to absorb a lot of our activities anyway. So I think more training in the community at the doctor's office, and maybe even to focus with the federally qualified health centers through our lobbyist group, the Maine PCA, and get us all trained so we know we're kind of doing the minimal, you know what I mean, and know what resources we can tap into, because I know we tap a few palliative care doctors once in a while, but it's very rare. And I think it's something that is so important. We're trying to keep our patients out of the ERs and out of rehospitalization and quality of life, but we don't have the training to do it. You know what I mean? We call all of our hospital discharge, all of our ER discharges, and they're so excited. You know, and they say, well, that's nice for you to call, but I'm like, yeah, but you know, I enjoy talking to you too, but you know what I mean?
Yeah.
We're just touching, we're just peeking the door open and peeking in, when we really should be saying, how about this, how about this, do you need that, you know? So I think one thing would be, a great thing would be to see if Eastern Maine or somebody is doing this. It would help us all if we got the navigators and we got the hospice volunteers, we got everybody just a tip of it so we knew where to turn. I do case management, and I'm an LPN, so I'm not billable anyway, but they absorb me anyway. So I would love to have more of that, and I know my colleagues, the friends, the RNs, and the other LPNs in these federally qualified health centers would love to be able to know what to ask and where to help them and what to do. So I think, you know, I hope it goes. I think they're making, you know, great moves to keep them out, but I think we need to be pushing for more palliative care on the legislative level, and we need to get this covered, because it's not just homebound. You know, to get home care, we have to be homebound. You know all that. So, I mean, when you get a grant, you get all excited, but when the door closes, then there's that, what's the finances, what's the bottom line? But, I mean, let's spread it around and try to get everybody involved and try to do this.
Yeah, and when we got thank you for those ideas. And I think I've written it down and I'm going to remember for the health services. But also, I feel like part of this gift that the donors through MDI Hospital gave was this chance to try this program and try to design it in a way that can be sustainable. And what I love is have a model that could then be transported to other critical access hospitals or other rural sites in Maine. I mean, access to palliative care cannot be taken for granted all across rural America. And so, how do we bridge that?
Becky
We're
Daigle.
down to just about 5 minutes.
Becky Daigle is here from Eastern Maine
From
Medical
Cancer
Center,
Care?
who could talk about maybe.
Okay.
Yeah.
First, we have a question over
Okay.
here. Who had your hand up?
Yeah, I was just thinking, I wonder if it's time to get political. Because really, there's nothing that administrators and legislators and insurance companies love more than thinking that costs are gonna go down. And she just made me think, if we're gonna reduce the amount of ER visits, that would be pretty important. And I'm surprised that that's not already included in healthcare insurance.
Yeah, you would think. I mean, there's a lot of literature that illustrates that the use of hospice benefits for the end-of-life journeys for people saves a lot of money. But not everyone has quite embraced that. Yeah.
They don't, but they tell you they want us to do that, but they don't tell us how.
Yeah.
You know what I mean? That's the thing, and this is such a good component. Okay.
Is it Becky? Becky, you want to come up?
Becky.
Okay, Becky, come on up. And while you're doing that, this question, please.
Yeah, I do have a question. Pain control, if you're on, you're a cancer patient on pain control in palliative care and with the opiate crisis, are you required to sign a contract with your physician?
Yeah, I mean, there's opioid rule, there's a whole nother talk, and I've had to learn them and relearn them, and I would say the way I'm managing it now is I have to have a conversation with the primary physician, and we decide who's gonna write the scripts and one person, and then manage it that way.
And there's an exemption too, isn't there? Palliative exemption?
So it seems like maybe that's one of the trends or the future is kind of figuring out that coordination point person model, you know, which is maybe what you're doing. Yeah, good. Okay, Becky, come up, introduce yourself.
My name is Rebecca Daigle, and I'm an oncology social worker at Eastern Maine Medical Center, Lafayette Cancer Center. I've been there about 4 years now. We do have a palliative care team that is housed every day, Monday through Friday. They support our patients on the continuum of care. So if you have a metastatic cancer diagnosis, they are initially referred right after your first day with your onc doc. Then you meet me, and I make sure that palliative care is in force as well. We also have the palliative care team at the Weber building, and those patients are referred by their PCP all over the county of Washington, you know, this neck of the woods, down east. The Weber building has, I think, 6 physicians. They're Monday through Friday. They do home visits as well. They have a nurse navigator in their office in the Weber building. They have a nurse navigator at the Cancer Center as well. They
Where's
use
Weber?
me at the Eastern Maine campus.
It's on the Eastern Maine campus.
Yeah. And I am their social worker as well. So when there's issues, I'm called. So I just wanted to clarify that palliative care is thriving well.
Thank you. All right. Questions for Rebecca?
Yeah.
Before she runs out the door.
What about self-referring?
I'm sorry?
Self-referring.
Okay. And we have another question.
Okay. So the way it works is that if you want to participate in that service, you would ask your PCP or physician to make that referral. That's the best way to get in.
Okay. Okay, and question over here?
Yeah, I'm just curious about listening to the conversation about access to palliative care, especially in kind of more rural areas. Does your program or do any of your programs utilize telemedicine to deliver similar services? And I wonder if there's any appetite to try to employ telemedicine as a means of extending the reach of palliative care. And I'm coming from a medical center in Portland, and we're exploring that concept. And I'm just curious whether you already have experience or whether you'd be interested in trying to explore something.
We are set up for telemedicine. We use it right now for genetics with Dana-Farber. That's how we're using it now. We do use it for our oncology docs for Millinocket. So there's a site in Millinocket in our center where patients are seen. For palliative care, we're not set up with that right now, but to get patients in, they use me to get transportation and to get rides. Patients see.
We're just about done, so any final words you'd like to say?
Just thank you for being here. Thank you for your thoughtful questions. Exactly. Thank you.
And thank you all, the panel. I think this was a great panel, and I would urge all people getting treatment